I think one of the biggest things for me was when every month GHS we have our medical care committee, which we have here at North Greenville, a medical care committee, but the system has the medical executive committee. And each month the campus presidents, we have a report that we kind of give at the main campus during MEC. And I would give an update on our central line bloodstream infection rates, and the physicians would ask a few things, and I was really trying to share with them that I thought we were doing much better. Well, after about the second or third event, Dr. Tom Diller, he's our VP of Quality, he kind of pulled me aside and he began to talk to me about what was going on, and he had looked in and done some analysis. And he said, "Mike, you're not doing really that good." And he said, "I've looked at it," and when he said that to me, it just crushed me personally, because I've been watching it and tracking it, and I'm like, I said, how can this be happening on my watch? Now, I'm not a physician, and I'm not the clinicians, but I'm the leader of the organization, and I felt very personal responsible that we were allowing central line infections to happen here when I look at the other LTACs across the state, and they're doing phenomenal, some of them with zero. And so I really took it personal, so I came back and I began to speak to my team and speak to our campus director of patient care services, met with the nurse manager, met with the entire clinical team, and then began to talk about how we need to really look at central line infections.
Michael and I had several conversations, and he's like, "What is it? What is it? What is it?" And I said, "They're not scrubbing the hub." So, I mean, and with his excellent direction, he said, "Well, that's it. That's what we're gonna focus on. We're gonna try it for 3 months, and if that's not it, then we'll go back and we'll start over and we'll try again." The 3 things that we actually did, and it was a progression of steps. It wasn't done all at the same time. It was a progression. When we saw that we weren't getting really the results we wanted with the first couple of steps, we formed the committee to look at all this information, and it took time to go through 43 records and paint that picture with the data. And then our initial concept was that it was maintenance issues, so we dedicated staff to changing the dressings and assessing the line need every day. Did that for a couple months and saw some improvement, but not the improvement we were expected, and that's what further pointed us to the accessing problem, because that's the only other thing you do with a central line. You insert it, you dress it, and you access it. So if it's not the first 2, it's got to be the third one.
These are the more complex patients with the complex infectious diseases that are out today, the more multi-drug resistant diseases. The majority of every patient out on the LTAC has some degree of infectious disease. The majority of all LTAC patients have some sort of line access, whether it's a central line or a PICC line or a port. And so I think you take your highest risk patients from your standard acute care hospital, you then coalesce them in one building on one unit, and your risk of transmission of infection through lines, I think, is much higher.
But we had a maintenance problem, and that was where our nurses around what we call scrubbing the hub. And if the nurses, they all know what I'm talking about, and probably the doctors too, but this is that hub they scrub, and it has a time that it says if you scrub it, you'll get the effect of that being a very clean hub before you administer the medication and so forth. And then each nurse that we would ask, they all had a different method. Some would use their watch. Some would sing happy birthday. And we realized there was so much variance that we needed a process. So I had this bright idea. I thought it was a bright idea. No one else liked it. But it actually said, well, we'll just try it. And so we had a nursing member to witness another nurse scrub that hub.
So they asked me to be the physician lead, the chair of the PCQC, so the Patient Care Quality Committee. And the idea there was to bring in doctors with nurses, with administration, to be able to attack what is our infection control and CLABSI process here at North Greenville.
Our rate actually, over the 2-year span, dropped 79%. So we were at a rate of 4.01, and now we're at a rate of 0.85. Countless lives saved, countless amounts of dollars saved. It's been an incredibly successful venture for us.
it's years of cultivating the relationship between administration and doctors, and really that's through Michael Batchelor, that even leads us to begin to create a specified quality committee that's multidisciplinary, that includes nurses, it includes techs, it includes doctors, it includes administration, and it even includes patients and families. And only through that relationship and that open communication and that humility of identifying administration issues that may be barriers to improving our quality, to physician barriers, to nursing barriers, can you even identify how you even need to improve. So it really is just, it's the culture that's created and the openness now of it's one team. It's administration and physicians and nursing that have to be on the same page anymore. It can't be isolated, and if it is isolated, you're never going to get past your issues.
Imagine going to Starbucks. I love Starbucks. And I'll get a cup of coffee. That's $2. So you take away about, 90 cups of coffee. It's about $180. It's about what it cost us to make this happen. It just took a lot of people getting together, really thinking about the patient, using some evidence-based practice, using some checklists, some things that we know that work, and really doing things outside the norm, and really talking about why we do what we do.